let's see. Today I actually do have a little bit of a slide presentation. I'm going to have to work my way through it. And there I go. Let's see. How do I get back to where I was? Thank you. Oh, okay. Thanks. All right. So why am I here? Well, the reason why I'm here is to give a community's perspective on the revised 2013 ART guidelines. Can we afford them, etc. And the community being the catch-all term for HIV treatment activists, PL-HIV and their loved ones, key population members, civil society organizations, blah, blah, blah. But it's really because of an argument I had online. And this was on one of the listservs that all seem to weave in and out of each other, like Health Gap and ITPC. And the discussion was referring to the guidelines, to the upcoming guidelines. And there are two camps in the community. And one is sort of, well, no, we have to be responsible. If the WHO goes off and does this, it's premature. The data, the evidence base is not so solid, and we need to finish the START study first. And the other side of the argument is full of hand waving, moral appeals, wishful thinking, and sloppiness. And I used to be on one side of the camp, but guess which side of the camp I'm falling into now? So. In this debate, one of my colleagues, and I respect him greatly, Nathan Geffen, wrote about his concern about the potential implications of revising the treatment guidelines. And as we've already seen, when the treatment guidelines change, many countries act, and they're extremely important. So these are the guidelines themselves, the actual early, as they stand, earlier initiation at under 500, but still prioritizing 350, and then some CD4 cell, some situations are irrespective of CD4 cells. So Nathan responded to this by worrying about the evidence base, and this was a conversation in January, so some of these things have changed somewhat. And first he tackled prevention, and he admitted that yes, there's some good data, compelling data on prevention, but he doesn't think that it's absolute, and we know it isn't absolutely absolute in all situations. But even so, he thought that on the balance, TASC probably works. But is it enough to convince policymakers? Well, as we've already seen, some policymakers are already convinced. But anyway, and then his real argument, I think, was had to do with whether there was adequate evidence for individual health benefits, and this really goes to the when to start question, which he pointed out that in HPTN 052, it didn't show that there was actual evidence of reducing disease and progression that we didn't already have. We already knew that because the threshold in the study was 250, and we already knew that starting when you get to 250 was inferior because of SMART and the RCT study in 80. So he thinks that the guidance change should wait until the results of START or Soprano, which have one of three likely outcomes. One, earlier treatment is better because it reduces disease progression. Two, no difference. Three, earlier treatment is harmful because of the increased side effects or reduced adherence. And then he moved on to the cost implications. And you can read what he says here, but he's right. We do have to be pragmatic. We do have to think about costs. So, looking at other, maybe mechanisms, he said, well, eliminating CD4 cell, we might be able to offset our costs by eliminating CD4 cell monitoring, et cetera. And he doesn't think it's a solution because the more impoverished places are using symptomatic or initiating treatment on the basis of symptoms anyway. He said that the other countries that do have CD4 cells shouldn't have to change their guidelines and move to worse practice. And places without CD4 cell tests almost always initiate with stavudine, which is probably harmful at higher CD4 cells. And he has a point there. But then he goes on and he says, none of this to say that patients who wish to start earlier and have an opportunity to do so should be stopped from doing so. And I read this and I thought, okay, I used to agree. I used to worry that when we had limited options, limited therapeutic options to switch to, that in resource-limited settings, the when to start question was still valid. But how will anyone have the opportunity to go on earlier treatment unless the guidelines recommend that they do so, and unless we have the money, or unless they have the money? And many policy I wanted to respond to that. Well, you can't put a price tag on human rights, but that's not actually true. It's wrong. Human rights do come at a price. We simply have to find a way to pay for them. And as HIV activists, we seem to have fallen back on our laurels, and we're not out demanding access to low-cost generic drugs that have been available in the U.S. Not the generic drugs, but generic formulations of drugs that have been available in the U.S. for 10 years, and we still don't have second-line treatments in many countries. Why do we consider that acceptable? But I want to go back to the when to start question, which is that I remember back in 1997 when we first started seeing some long-term side effects of ARDS, and all of our hand-wringing then, because we thought that maybe we had caused lipodystrophy, maybe we had scarred all of our friends. But once you have multiple regimens, you can't really, and with different toxicities and switching options, you can't really do just one when to start study. You'd have to do multiple when to start studies with multiple sequences of one regimen, starting with this regimen, switching to this regimen. It would take years and years and years. And this is all just to look at, as I think Julio said the other day, just to look at a few-year period of waiting. And now we have a situation where there's maybe possibly also potential benefits from starting early. We have the prevention benefit that we've been discussing, but we also have, potentially, with the cure research, we know that with the data that came out in January, maybe the people who start earlier are going to be the first people to potentially have an option to benefit from some of the cure research. And this is an option that, this is something that has to be part of the informed consent. Now, if I start earlier, do I have a better long-term shot at moving on, at doing well in treatment? But, the cost is an issue. And the fact that there aren't the regimens in the resource-limited settings is an issue. So the solution is not just to say we don't have them, but to demand them. And to make sure, and to use the experience of WHO's treatment optimization, use the experience that we have with MSF, using simple regimens with nurses and self-management, patient self-management, to demedicalize treatment, to make it less cheap, to make it deliverable in the most remote parts of sub-Saharan Africa. Because if we keep the current model, we're just not going to get there. It's not going to happen. So even with places with CD4 cell, this is the other thing. When Nathan said that dumping CD4 would be a lower quality of care, but CD4 cell measurements equal rationing care. It's rationing care. And the thing about it is it's not just rationing people with higher CD4 cells. It's not just rationing people with higher CD4 cells. It's rationing all comers. The process of going and getting a CD4 cell count eliminates people from treatment. I mean, people drop out of care. They disengage in care. And what happens when people disengage in care? Sidney Rosen and Fox showed that of people who present to care, many of whom already qualify for care if you had their CD4 cell counts, in the various visits that they have to go and go through the ART preparation process, most of them will drop out. And 70% of those will never come back to the clinic, and they'll die. So, status quo is unacceptable. We can't have someone come in who tests positive, who's looking for a solution, tell them you have 400, or now we're going to say like 550 CD4 cells. That's too soon to start. We'll check you back. We'll check back in 6 months, and they won't come back. Or if they do come back, it'll be when they have cryptococcal meningitis. And that's the reality I think we're living with. It's not acceptable.